Hello, we are live today to talk about one of my favorite topics, which is the brain and functional neurologic disorders, and specifically looking at a very recent research in this area on functional connectivity and FND. And I have to give the disclaimer, this particular study, this is a preprint. It has not yet been peer-reviewed, so if things change when it gets published, I will let you know. But I am super excited to dive in. And thanks so much for coming live, or if you're catching this recording afterwards. My name is Julie Hirschberg. I did not do this research. I am a neurologic physical therapist. I'm the owner and founder of re+active Therapy and Wellness. We're in the Los Angeles area, and I love to read research. And this particular article is from the amazing Mass General Hospital group. My friend Julie Maggio is another PT. Her name was on this paper, and she actually had texted me this paper. And Julie Maggio, Heather Salon, and I, we text each other all the time. All of our nerdiest thoughts and articles. And this was one of them. And I dove in and I was like, I have to share this. I know it's a preprint, but it's so fascinating. And I think what is most important here is the why. Like, why is this fascinating? Why is this so important? And I think when it comes to some of the functional connectivity imaging studies in FND, what they're really showing us is that this is a very real, a very brain-based disorder, that it's not in your head, it's not made up. And oh, hello from Australia. It's the morning. We're kind of moving into the evening here in LA. But that is what keeps coming up again and again and again in these studies. So let me share the study name. So here it is. The preprint was just published in June of 2025, so just last month. It's called Functional Connectivity Gradients Reveal Altered Hierarchical Cortical Organization in Functional Neurologic Disorder. I know that's a mouthful. The first author is Christina Westlin. And again, fabulous group from Mass General Hospital. They have an FND research lab. They do a lot of imaging studies. They're doing really important work in this area. And by the way, I got an email the other day and they're like, what is FND? And I was like, thank you for asking that, because sometimes I forget to describe things to people. So FND, Functional Neurologic Disorder. This is a neurologic disorder where the connectivity in the brain is the issue. So the functional connections in the brain, that's why the name Functional Neurologic Disorder, or FND. It's a common neurologic disorder. We see it a lot at re+active. We've run an integrative transdisciplinary program for people with FND. And I'm kind of obsessed with the brain science here. The research in this area has grown and grown every single year, every single month. There is new research coming out, particularly to try to understand what is happening in the brain, because it doesn't show up on our typical imaging, like MRIs, for example. But you can look at other types of imaging and at least see some of the connection issues that have gone awry. And that's what they did in this study, where they looked at functional connectivity gradients and saw that there are distinct changes in the brain for people with FND. And I think it explains a lot. It explains a lot. Now, I have to tell you, I had never heard the term functional connectivity gradients. I don't live in the brain imaging world. I don't do this type of work or study. I'm a physical therapist, so I work with people to help them get back to life. However, I have read a lot about the networks and connectivity changes in FND, and the functional connectivity gradients is another way to look at this. And I will say, I went down a little rabbit hole, and I'll share these in our newsletter. So if functional gradients is new to you, this has been studied in other disorders to see that there's some of these changes. So there was a big study in MS. There was a whole, in 2022, there was a whole brain imaging journal particularly dedicated to gradients. And I read just kind of the intro to that journal, of that special edition, because I was like, what are we talking about with this gradients? Because this was new to me. So if you're like, what is this? You're not alone. Like, I was like, what is this exactly? You know, if you're also not a clinician, or this is new to you as well, what we think about with these gradients or connectivity, I think about this as the like brain's internal GPS or maps and how things are connected. And we kind of have like highways and side streets and all kinds of connections. It's really complex in the brain. This is one of the reasons I was cleaning out things, by the way. I have these stickers that say one brain. This is Julie Maggio and Heather and I, my fellow neuro PTs, were kind of like really big proponents to remind folks there's only one brain. These things that might be associated with your emotional world they do interact with all of your other worlds, because you only have one brain. Mim, hi Mim. Mim is here, by the way, from the UK, joining us at re+active, and she said 3.5 hours of therapy today, and it isn't enough, so here I am. And Mim, I hope that you got that body braid working for you, so you could take it to Disneyland. A lot of folks, by the way, when they come and work with us, do fun things like go to Disneyland, and I'm so jealous. I haven't been to Disneyland in like a couple of years, Mim, so I'm just going to be like living through you to go to Disneyland. So anyway, side note, Mim, thank you for being here. I hope you're like cooling down also. It's a much warmer day today. So we're going to talk about these functional connectivities, this internal GPS of the brain. And this research really helps us understand the why behind FND symptoms, really to look at these brain networks, what's going on, and what we can do about it. That's what I care about, right? So we're going to cover the study, and let's actually dive in. I'm going to stop sharing this. But I will put the link to this article as well as those other gradient articles in our newsletter this week. So if you're not on our newsletter, you can comment once this is posted. You can send a DM newsletter, and I'll send you the links to sign up. So let's start off with why they were looking at this specifically. And I've talked about this a lot before in looking at other literature, is that in the past, FND was known, way back as like hysteria, primarily in women, and primarily a psychological or psychiatric disorder. So from hysteria to conversion disorder to functional neurologic disorder. And that pathway from only understanding it as psychological to really understanding it as multifactorial and these functional connectivity issues really came from these types of studies that dove into what is happening in the brain. And what I think is really cool about this study is that they actually compared people with FND to people with psychiatric disorders, to healthy controls, to be able to piece apart what might be causing what. And guess what? People with FND were not like the people with the psychiatric disorders. We all knew that already because many studies have shown us that as well. But this study really confirms that no, this is not a purely psychiatric disorder. So they talk about resting state. So you're in a resting state. Functional MRI imaging. So this is a little bit different than an MRI that you might do for a diagnostic. These are typically just done in research studies, but they've been done in multiple times in FND and shown that there are changes in the brain across several networks. And I want to talk about 3 of them just really briefly. This is like a little diagram that we had created for a presentation to look at the networks that are highly influenced in functional neurologic disorders. That's the salience network, the default mode network, and the frontal parietal network. And these have been shown time and time again to be altered in people with functional neurologic disorders. So they've had these studies, they've looked at these networks, but these studies and approaches assume that there are like these discrete network boundaries or connections, when in reality, things are really fluid in the brain and lots of interconnections. So this is where the idea of gradient mapping comes in. And so this is just I would say like a technique to look at imaging, to look at more of a gradient rather than these distinct areas. So again, I am not a brain imager, mapper. I love the brain, obsessed with the brain. So I'm sharing with you kind of the basic simplified version of this gradient mapping. So we know these networks, but we also know and understand that they connect and interlink in many different ways. And the gradient mapping helps us to visualize that. And basically, you get these gradients, which are representations of functional connectivity. And this goes back to the name of the article. These gradients in the cortex, so we're looking at the outer layers of the brain, they capture these like transitions in connectivity, which reflect the hierarchy in the brain. So the hierarchy of the cortical organization, that's by the name of the article. So as I mentioned, this gradient mapping has been used a lot. There's, and again, I'll put in the newsletter a whole link to a whole journal that was a special edition that was really looking at the advances in this area. It's really fascinating. But there's 3, so just like I showed you those 3 main networks, there's 3 main gradients that are important here. Gradient 1, which is this association and sensory motor gradient. And this actually, it like goes from the default mode network, sensory and motor networks, and the salience networks. Maybe I'll bring this picture up again. So think of the gradient 1 as kind of being the right side of this diagram. And then gradient 2 is the visual somatomotor gradient. This is not in this picture, but visual and somatomotor sensory systems. And then gradient 3 is called the representation modulation gradient, but this actually differentiates the default mode network and sensory networks from the attentional networks. Now, if you have been kind of looking at the neuroscience in FND, you will be like, okay, I know these are important networks. The default mode network tends to be too active in FND, for example. Same with the attentional network. So another important piece that they talk about in the intro to this study is to connect the functional connectivity to the predictive brain. So I know we have shared this before, and Chelsea actually did a really lovely reel about the predictive brain. And so I want to just give a very brief reminder of what this is. So essentially, the predictive brain looks at how the brain really does things quite efficiently to predict what's going to happen, right? So in normal movement, we have an intention to move, we plan it, we execute that movement, and we give the brain feedback through our sensory system. Our brain also will predict things. So for example, like I was on my run this morning, if there's a particular spot that I expect, like I like to run in the middle of the street and there are those little like reflector things in the middle, my brain will actually predict like take a bigger step, right? Because it does it so frequently, right? So the brain will predict. And then if things change, my brain will update those changes. So this can go awry, and it is thought to contribute to the symptoms in functional neurologic disorder. So in functional neurologic disorder, we can see this intention to move, the brain overly attending to the movement and overly using the predictions. So those predictions are kind of overriding some of the feedback. So think about my running, and I have those little reflective things in the middle of the road. Well, for a few weeks, they were redoing the street and none of those were there. So my body and my brain started updating the prediction, like, oh, those little things are not in the middle of the road. We don't mean to take a bigger step over them anymore, right? And then when they ended up there, it went back. But in what seems to happen in FND is those predictions don't get updated, and the brain is kind of overly relying on an old prediction. There also are changes in the planning of movement. So there's abnormal connections there. There's changes in how there's execution of the movement. And there might even be impaired or inaccurate feedback from the body through the sensory loop. So this is not what the article was about, but they highly reference this predictive brain model. So I thought it was really important. So there's the briefest overview of it. So they talk about how looking at the functional connectivity through these gradients can really help us to understand where along that pathway that I just showed you, things might go wrong and why they go wrong. And this could really give us a very important target for our therapy. So, I'm so excited that they did this study because I feel like it brings in so many important pieces to understanding FND. So let's talk a little bit about who was in this study. They had 64 people with FND. I think that's a pretty good amount. They had people that had FND motor symptoms like tremor, dystonia, weakness, for example. And then they had people that had FND with seizures, so functional seizures. And then some that had both, right? Because we could definitely see both. And then they had people, just a group of people who had psychiatric disorders. So they didn't have FND. So these people had depression, anxiety, or PTSD. And then they had matched controls. I was trying to think of the word for that. So matched for age and gender controls. So this is a big plus to the study, that not only could they look at the brains of people with FND, but they could look at and say, is this different from a healthy control? Is this different? And how is it different from a person with a psychiatric disorder? Because what is really helpful and like really, to be honest, I hear this all of the time. People with FND are frequently told, well, you're just stressed, or it's just PTSD causing your symptoms, or it's just depression, or it's just anxiety, just many things. And in order to really piece out, well, is it just that this is one way to do it, right? So this is a way to actually show, and they showed it's not just any of these things. The brain and how it is working and those connections in the brain are very different from a person with anxiety. They're very different from a person with PTSD, very different from a person with depression. And they did some really lovely statistical analysis to show that, and to show where some overlap is and show where it's not. And that is just so, I feel like every neurologist, psychiatrist, every healthcare professional should really be reading this type of work, because it flies in the face of so many myths that are out there on FND. It's not a psychiatric disorder. So the other thing that they did, so they did imaging on all these folks, and then they also looked at their symptoms. They did different questionnaires, but symptom severity, because what they wanted to see were changes in these gradients or networks correlated with their symptom severity, so that you could actually say, okay, well, the brain is different, and the amount that it's different actually correlates with the severity of your symptoms. That's really, really powerful. So now what they did, they got all the imaging, right? So got all the MRIs. Then they did the gradient analysis. Now, this is where I got to tell you, this part is like, woo, over my head. But essentially they did a diffusion map based analysis. And I could even read this to you, and you might, unless you do this all the time, be like, what is this? But I'm going to read it to you, and so that you can laugh with me. Non-linear dimensionality reduction technique that can capture the dominant dimensions of spatial variation in high-dimensional functional connectivity data through a set of low-dimensional manifolds, gradients. And so they could create matrices for each participant. And then they do the statistical analysis on that. So essentially, they're taking images and applying a lot of, let's just call it math, to create a visual representation of these gradients to show functional connectivity. I think it's really cool. It's not what I do on a day-to-day basis, but I do have to tell you, I read this article a few times, and I was like, I think for me, I'm such a hands-on person. Like, I'd like to see somebody do this, and like show me how they're doing this. But you can imagine they're taking a bunch of images and running them through a process to have a visual representation of the functional connectivity. So then they're comparing them between groups and correlating them to symptoms. So that's how they were analyzing the data. So very, very interesting. Here's what they found. So I'm going to show you one of these. I love looking at these. Oh shoot, I didn't get the image. Okay, well, I'll show you one of the last figures in this is actually looking at the correlation of symptoms to the brain changes. And so you can see that with gradient 1, 2, and 3, and you can see that sloped line. So you could see the correlation, I think on these, the correlation coefficient was like a point, like between 0.2 and 0.4, not a huge correlation, but a significant correlation still between symptoms and the brain changes. There's another figure in this, and I did not capture it on my phone, I guess, but in the other figure, they actually show what are the differences in the gradients. They found significant alterations across all 3 gradients. In the mixed group, so these were people with mixed symptoms of FND relative to controls, and these were associated with individual differences in their symptom severity. now what were those changes? So in gradient 1, the connectivity shift it shifts in the sensory motor regions to more association like profiles. Very, very interesting. So that's a connectivity shift, right? So the connectivity is different. Gradient 2 was altered visual somatomotor differentiation. So I think of this as kind of like a smudging. It's not well differentiated. And then gradient 3, they showed reduced separation between some of these representational and modulation regions. Now, I want to talk about what all of these things mean, obviously, but I wanted to give you the results. They also found overlapping and distinct differences between FND motor and FND seizure subtypes. And I think that's not surprising to see some overlap and some distinctions. But all of the pieces together showed that the hierarchical functional brain organization is different in people with FND compared to other people. Now, I saw a question or comment on here. What about those of us with FND and PTSD and anxiety? Of the people with FND, did they only use people who didn't have psychiatric disorder or diagnoses? You know what, ma'am? I was thinking of that exact question. Let me go back to the people to see what they excluded on, but I do not believe they actually excluded based on those things, but they controlled for those things. So let me just look again at the people in here, because as we know, in any neurologic disorder, depression, anxiety, even PTSD are common. I mean, they're common in humans in general. It would be very hard to disclude, like to have a sample of people with FND who did not have those things. Okay. So the only reason people were excluded in the FND group, thank you so much for this question, is if they had neurologic comorbidities. So like they also had epilepsy, they also had Parkinson's disease, they had poorly controlled medical problems, active substance dependence, psychosis, or active suicidality. So they were not excluded for having PTSD, anxiety, or depression. Now, I will say something that was really, they dive into a lot of the distinctions in some of these subgroups, and I'll hit on some of that as well, where there were things, so to your question, a lot of the group had these other diagnoses, but their brain connectivity changes were different than just having PTSD, anxiety, and depression. There's something unique about FND and those things. So thank you for that really beautiful question. Now, I want to hop into the different gradients and connections. So that gradient 1, which was the association sensory motor gradient, and includes things like the default mode network. This gradient, or like think of it as like almost like a connectivity, a fluid connectivity area. This has been proposed to reflect a continuum between regions that are involved in representing prediction signals to those involved in signaling prediction errors. So remember in that predictive brain diagram, I talked about the higher emphasis on prediction, like prior predictions, and not updating with prediction areas. That correlates with this gradient 1. I think that's really fascinating. And again, this, the idea of this kind of predictive brain explanation of FND, this, I would say, kind of supports that. The other thing, so again, comparing, so Min is saying that FND rules over it all. Like, it kind of does. So at least the brain changes that are, and the connectivity changes that are occurring in FND seem to be the thing. They're a differentiator, right? So these are the things. And I think what's nice about this is that it kind of is like the anxiety or the PTSD, it's part of a person's picture. We don't want to ignore those things, but it might not actually be the thing driving the symptoms. It might just be part of the person's bigger picture. And this is why, like, just treating the anxiety or just treating the PTSD might not be helpful for the other symptoms. In some people with FND, I'm not saying all people, but in some people with FND. Okay, so I have to read a few things that they say here. So from this predictive processing perspective, the findings suggest that regions typically involved in signaling prediction errors, okay, this is the part that's not working well in FND, are instead exhibiting connectivity profiles similar to areas involved in representing predictions. So this is very consistent with those theories that have proposed. There's this like overly strong prior prediction at work in FND, and those predictions are not updated appropriately based on incoming sensory input. So this confirms that predictive brain, a part of it, right? So the other thing that it confirms or consistence is this increased like over connection or over integration of sensory motor areas. And this particular group from Mass General has found this with like connectivity between the primary motor cortex and the insula and cingulate. Like some connections between multiple areas of the brain, normal. Overly connected in FND. And so that means some of the attentional pieces, emotional pieces might actually be almost kind of like wires are crossed, right? And they're more connected, enhanced connections. Some areas we want enhanced connections, others not so helpful. So the overall idea is that the organization is like disrupted. And from a clinician standpoint, from a patient standpoint, we want, like, it kind of feels like that, right? Like I hear from patients, like, it feels wonky. Like my brain is doing wonky things. I'm saying one thing, it's doing another thing. Like it's really disorganized and disrupted. And from a clinician standpoint, I'm going like, where did that go awry? Is it like the sensory feedback? Is it interoception? Is it autonomic? Is it the motor control? Like what are the psychosocial pieces contributing? And we're essentially like trying to like play operation in the brain without sending wonky signals. I mean, we're not doing any operations, but you know what I mean? Like we are trying to reestablish and reorganize those connections. And Trina is saying, I always call my walking wonky. Like wonky brain, walking. It's certainly not going as you're trying to command it to go, right? Like it's doing its own thing. So that's just gradient 1. This stuff, y'all, it just blows my mind. Gradient 2. So gradient 2 is that visual somatomotor gradient, and it's thought to reflect the organization of the sensory systems, also one of my favorites. And in the mixed FND cohort, they had decreased gradient 2 values in the lateral prefrontal cortex. And this was a difference from both healthy controls and people with psychiatric disorders. These are attentional regions. And what they suggest is that the attentional regions are shifting to these other areas. And this could reflect abnormal attentional modulation of sensory systems, so that you have these predictions and they're not properly updated based on incoming sensory input. I see that all the time. Emily is saying, I have lots of pains when I'm walking or after doing anything physical. And so something I think of, Emily, when we think of these connections in the brain to kind of have gone awry, sometimes people will experience sensations or abnormal sensations or pain in response to a very light touch sensation. I think of those as connectivity issues that have gone awry, and we just need to figure out where that is. By the way, this gradient 2, some of the sensory pieces really support all this growing literature about altered sensory processing in functional neurologic disorder. Clinicians, this is why we need to test it and bring it into treatment. It's so very important. Gradient 3. So gradient 3 was this representation modulation gradient, and it differentiates, remember, the default mode network and the salient network, but it differentiates, and those regions are heavily involved in predictions and predictions errors, as well as the precision of those things. And again, people with FND had increased gradient 3 values in these modulatory regions and decreased values in representation regions, suggesting less distinction, we want distinction between some of these areas, less distinction between these processes. And this is what they say. This pattern may reflect atypical predictive and precision setting processes, potentially leading to that dominant prior, meaning your brain is kind of dominating with prediction instead of updating it. So again, really kind of nice support for that predictive brain piece. Now, I want to read this piece, particularly to Mim's question here. So they said, notably, the decrease in gradient 3 values within the anterior cingulate cortex was robustly found relative to people with psychiatric disorders and remained significant even when they adjusted for the presence of depression, anxiety, PTSD, trauma burden in the person with FND. This is a kicker. Honestly, this is giving me chills, indicating specificity to FND beyond a shared pathology or risk factors with those psychiatric pieces. So let me just say this again, because I think this is so very important. The changes that they found in this particular connection, in this particular area of gradient 3, was very, very different than what they found in the psychiatric control group. And it remained significant even when they adjusted for the person with FND having a psychiatric comorbidity, depression, anxiety, PTSD, or trauma. So again, much more support for there's something else happening here in the brain, and it is not just anxiety. Okay, so is it Tina? Asked, can someone develop this after a motor vehicle accident, whiplash, unresolved concussions? 100%, and this has been published in the literature as well. Somebody could develop a functional neurologic disorder after, it often happens after some sort of accident, neurologic disorder, incident. A concussion is a neurologic disorder. You can develop FND after a concussion. A concussion is not FND, but you could develop it after. Absolutely, you could. One last piece here is the comparison between groups. So the FND motor group showed patterns that was fairly consistent with the mixed groups, but the FND seizure group was less robust. It was also a smaller group. So for gradients 1 and 2, for example, there was not a lot of overlap between the motor and seizure groups. So this it's a piece of evidence that shows we really need to take each person individually, that there might be some differences between the different types of people with FND and the different symptoms with FND. So this is very, very important. Now, I want to point out, I think about this with all of these types of study, and I think it's really beautiful that the authors talk about it as well. We don't know when we look at a person's brain. We don't know when in time it might have changed. So we don't know these altered connectivity that we see in FND. Is that what caused the FND, or is this a compensation for the FND, right? So it's a classic chicken or egg. We don't know. Now, this is where, as a clinician, I'm like, well, let's send them to reactive and let's do this pre and post therapy so we can actually see what has changed, right? And so like Wendy is saying, does research show what a healed FND brain looks like? No, nobody's done that study yet, right? So that would be a beautiful study. If we took all of these people, so there were 64 people here, if we took all of them and we had these baseline fMRIs that showed these gradients, gradient differences, and then had them come, I'm just going to say they're going to come to reactive, they're going to do PT, they're going to do OT, they're going to do speech therapy if they need it, psychology, yoga therapy, and then we're going to reimage them. Do their brains start to look more like the healthy control brain? Do those gradients shift? Do they restore to a similar gradient for somebody else? I don't know, but I want to know, Wendy. I think it's such a great question. And like, to me, when I think of what we do in therapy, like we're really trying to help somebody get back to life. But in my mind, we're doing that through means that would actually change these brain pathways, change these connections, so that the person not just has them in the moment, but can do this and take these changes with them forever, right? And so we don't know. We don't know what a healed FND brain looks like. And here's the thing, we don't even know what like a healthy brain completely looks like, right? Because we're all so different, right? And when it comes to FND and many of the other disorders that I see, like we have folks that are neurotypical, we have folks that are neurodivergent, right? Or I like to say that I see a lot of people with neurospicy brains, and we already, like, their brain already is functioning differently, already has different functional connections. However, not every neurodivergent brain develops FND. So what would those differences be? This study didn't do that. I would love that study. I'd love to know what that looks like, because I think that would show us something else, right? So it's a really, really good question. And in a disorder that is so heterogeneous, I think it's hard to do some of these studies. I'm getting like really weird lighting here, and I'm really sorry if like all of a sudden my face is glowing. I'm like sipping away. At least it's glowing on mine, like almost green. I'm sorry if that's like really obnoxious. Another question, is this video recorded and something we can access later? Yep. It is recorded and I'll post it right after, so it'll be on our profile. And if you're not on our newsletter already, you should get on it. We send a newsletter every Friday to clinicians, every Monday to patients. You can comment once this is posted. You can send me a DM for newsletter and I'll send you the link to sign up. Somebody else asked, do these findings apply to 3PD dizziness? They did not study that, but 3PD is a type of functional neurologic disorder. And some of the similar brain network changes have been found in 3PD. So what I would say to you, this study was not on 3PD. Do some of these findings or ideas or philosophies, theories apply? Absolutely. Particularly the predictive brain. I would highly recommend looking at that piece in terms of 3PD. That has definitely been correlated. Okay, Mim says, while it might not be ethical, I think you could very much identify people at a high risk of FND and see if they display the changes. Oh, yeah. So, for example, she says, I had PTSD, fibro, CFS, ME before FND happened. I think about this idea a lot, Mim, and I know this is not what they were getting at here, but what the ultimate goal would be is to have some biomarkers, some brain markers, and then, yes, like I think we can prevent FND from occurring in a lot of other disorders. So FND occurs highly with Parkinson's disease, a higher rate in folks with autism, higher in folks with multiple sclerosis. We see higher rates in those with hypermobility. We see higher rates in folks with PTSD, as you were saying here. Could there be ways that we can empower, inform, educate, provide really informed types of physical therapy, occupational therapy, psychology, speech therapy to prevent this? I think we could. I do. And I think that would be, I think it would be really empowering for people. Yeah, I'm with you there. And yeah, Amy says, maybe a multi-site clinical trial. Yes, this is what we need. Sign me up, Amy. Amy's at the Cleveland Clinic. Amy, when Cleveland Clinic does this, we will be a site with you. And Mim says, any clue in PT could have looked at me a few years ago and thought, FND might be in her future. Would be interesting to see if changes or before symptoms show. Yeah, and I don't know that we are there yet, Mim, but I do think, so here's something that I think about, like if we go back, I'm going to just go back to this predictive brain model here. So if we go back to this predictive brain and this theory of how the brain changes might cause FND and this process, well, if a person has some disorders that alter their sensory processing, right? And so we could say this about a lot of things. Even in PTSD, it alters sensory processing. Well, we automatically already know that person might not be getting great feedback from their body. We also know the same thing in hypermobility disorders. We also know the same thing in autism, that there might be these differences in sensory processing. There, Mim, is where I might say, so let's just say hypothetically, a PT is working with somebody, they might assess that and really start implementing sensory training and sensory pieces into this person's life early on. And maybe they wouldn't develop FND, right? Now, Not everybody with PTSD develops FND. Not everybody with autism develops FND. Not everybody with Parkinson's also gets FND. So there seems to be kind of a special mix of something, and I don't have all those somethings, but there are some things in the literature that we know, but maybe it's this functional connectivity, and that is, you're right, it would be nice to know and intervene early. And as Trina is saying, I have Huntington's too. So yeah, so great point. I think movement disorders are a really big one where you could also develop FND on top of that. So I'm just going to, before I log off here, I just wanted to share the article again and remind you this is a preprint, so it has not yet been peer reviewed. It's in the peer review process. It's called Functional Connectivity Gradients Reveal Altered Hierarchical Cortical Organization in FND. And we just nerded out on the brain for like almost an hour about this. And I just love your questions and your comments so very much. So Boss and Mama Bear, hi, says my daughter is odd ADHD, autistic, ADHD, just for those that don't know, CAPD, FND, PTSD. And now yesterday her daughter thinks she's having seizures that look like absent seizures. This is a doctor at a well-known teaching hospital university setting. And I just want to say it's common to have those things together. I'm not sure what types of seizures she's having. I will say the nice thing about, there's nothing nice. Let me not use that word. Something that helps in understanding what type of seizures they are. We have some tests, EEG. EEG will very nicely, definitively tell you, is it functional seizure? Is it an epileptic seizure? And then really direct you towards very clear treatment as well. So those are very treatable. Yeah, holistic somatic OT. Oh, what a beautiful name. Thank you. You're welcome. You're welcome. Thank you for coming. Very exciting article. I know. Oh, hi, Shane. Thank you. I really enjoy learning more. I love learning this. I love all the learning. Mim, you are here after 3.5 hours of therapy. I hope it is in the air conditioning though, and that you're staying cool while learning. This was really great. I just love you all so much. And you all voted, by the way. Every week I'm like posting on my stories because I get so many great articles to read, and you all have voted on these topics. So stick with me every week and vote on a topic, and I'm going to talk about things. So thank you so very much. And again, if you're not on our newsletter, send me a message. You can sign up at reactiveeducation.com if you're a clinician, or reactivept.com if you're a patient. Get on our newsletter. I'll send out this article. I'll send out the recording as well, and all of our resources. I can't wait to see you next week. Thanks so much.